This is part 2 of our video series, Understanding Hormone Replacement Therapy. Let's continue to listen to our two extraordinary menopause clinicians, Dr. Audrey Buxbaum and Virginia Reath.
Well, actually, a question just came up from the audience here, and when we're talking about all these different kinds of hormone replacement therapy options, the question is often, how do you know where to start? What do you give? What's the dose? What are you looking at? I'm going to take this opportunity just for a second to talk briefly about perimenopause, because for me, as a clinician, that's an area that I've really focused in a lot. So I'm seeing, as we know, that you see the continuum of hormone, and what you see lots of times in the years sort of post 40, 45 to 49, 50, you're seeing really erratic, actually, hormonal levels. You're seeing actually estrogen can really be labile, and it can really spike. One of the reasons that we see increased bleeding in women in perimenopause, but they're still having a period. So they're not being seen as a candidate for any kind of assistance in medication or in treatment. And that is, I think, a great failure on the part of gynecology and people who are prescribing, because that is often the place when women really start to, one, their stressors are starting. They've got adolescent children or younger children. Their parents are beginning to get sick and die. Their marriages are under fray. Their financials, their solvency. There's a lot of stress happening in these years. And a lot of women that we see also in New York are, really geared. They're professional women. They don't have, but you're looking at women who come into you who are sleep deprived, and maybe they've had weird periods where they haven't had a period for a couple of months, and then suddenly they'll have a period for 6 months every straight up. And they start feeling like, what is going on? I'm feeling a little nuts here. So they'll have increased levels of anxiety. They'll have sleep issues. A lot of classic menopausal issues, but you might run their FSH or an LH, or you might run some blood on them, if you do, some people don't, and find that, you're not menopausal. So for that person, I think it's really important that you look at the hormone that's really dropping off first. The hormone that drops off first is progesterone. Progesterone is made from ovulations. If you don't ovulate, you're not going to make progesterone. So you start to see that as being an area where women will respond very well to lower dosage, sometimes even over-the-counter dosages of progesterone. So then as we move into symptoms where now your symptoms are more increased, your flashes, now you haven't had a period, haven't had a period, haven't had a period. I think both Audrey and I think a lot of our colleagues certainly know to treat earlier than what they say is the menopause definition, which is no menstruation in a full year. I don't know how anyone can look at a woman across the table who's suffering, you can see it, hasn't slept, vagina is as dry as as a desert plateau, has even had friction burn from masturbation or whatever, and you want to help that person. So coming back to dosaging, where would we start? And where would you start?
In the menopause transition, if someone doesn't have a contraindication, if doesn't have a reason that they couldn't go on a low-dose birth control pill, and obviously it's a shared discussion with my patients, but that's often a way to regulate the hormones, to help take out the ups and downs that can exacerbate PMS, PMDD, bleeding irregularities, and some women do really well, and I have to kind of fight with them when they turn 51 or so to get them off of their pill and take them to the next step. So that's something that helps. I have some patients who I will have them on progesterone, and we use the micronized progesterone, as I mentioned, never really the synthetic progesterone. The typical prescription dose is 100 milligrams, and the nice thing with the natural progesterone is it makes women sleepy, so taking it at bedtime can really help them with their sleep. It can make their periods lighter. Sometimes we'll try to cycle them so that we can do it for just 2 weeks every month. Sometimes I find their cycles are too irregular to be able to achieve that, and I'll use it nightly in those women because it also has this calming effect. And then when they no longer are bleeding, then it's time, and even sooner, to introduce estrogen. And I usually when I start with an estrogen patch, somewhere in the mid-range. The patches come anywhere from 0.025 milligrams, which is a low-dose patch, to 0.1 milligram patch. So for example, if I have somebody who's had to go through menopause abruptly because she had to have her ovaries removed, I'll start with the 0.1 milligram patch. Or if I have younger women who are under 40 where I really want them to be on estrogen for bone health preservation, it prevents osteoporosis, I will use a higher dose estrogen patch. Otherwise, in most women, I'll start 0.0375 or 0.05, and then we have room to go up if they continue to have symptoms, and we have room to go down if they have other symptoms related to the estrogen, such as breast tenderness or palpitations or bloating. So I don't have a hard fast, this is the amount you should be on. I have some patients who find that they're very sensitive to medication, in which case we'll start lower and then we again have room to move up. The question that was just raised from the audience is, what about women who are menopausal who have no symptoms? And I incorporate into my annual visit at least a quick overview of the benefits for hormones, and so I will always mention that they're good for bone health, that they're good for heart health, that there's this window of time in which it's safe and effective, and that for almost all women the benefits outweigh the risks, but that the main indication, at least by the FDA, is for treatment of vasomotor symptoms, but it is also FDA approved for osteoporosis prevention. So I do have women who schedule their consults with me to talk about menopausal hormone therapy, even if they're not terribly symptomatic. And in fact, a lot of them, when they've then gone on hormones, realize that they feel better.
Yeah.
Even if they weren't feeling crummy, even if they didn't think they had symptoms, right, they feel better. They are less fatigued. They have more energy. They realize their sleep is better. They're a little less irritable. So I'm certainly not. When I first came into practice in the 90s, while the Women's Health Initiative was going on and while we were all being trained in hormone therapy, I, at that point, encouraged every menopausal patient to go on hormones. I certainly don't do that necessarily, but I make it clear that it is available to everybody. Right, well that's a separate question, is when do you stop hormones? And, yeah, well, and actually, I will often, women want to go off. They feel like they still have that subtle message of it's bad for you. And so I'll tell women they can try to taper down and see how they feel. But if they don't feel good off of hormones, I have patients in their 70s and 80s on hormones. Yeah. I went off mine for a year and I just went back on. IUDs have gained a lot of popularity in younger women as well for contraception, especially since there have been more concerns about access to care and abortion rights in the United States, at least. So it is a procedure. I mean, you have to have it inserted. It's painful. It can be associated with irregular bleeding, but it tends to make the lining of the uterus thinner, so it actually decreases uterine cancer. And it is a way to manage bleeding, particularly, as I said, in the menopause transition. And it's an off-label use for protecting the endometrium for women who are on estrogen, but who for some reason don't tolerate the natural progesterone. They may get headaches from it. They may actually feel a little depressed on the natural progesterone. So it is an option. And I like it in the women in the menopause transition because, as Virginia said, we don't wait till women are a full year out with no period if they're suffering. And we will start women in their 40s on estrogen if they're having hot flashes and sweats and they've been on their progesterone but they're still symptomatic. And then we end up sometimes chasing irregular bleeding. And luckily we could do sonograms, we could do biopsies. I mean, it's that balance between treating their symptoms and making sure there's nothing else worrisome going on. And again, I think the media from 2002 made women very fearful of hormones, and we do a lot of work reassuring them that risk of breast cancer is extremely low, that risk of uterine cancer is extremely low, that we've got the transdermals to avoid the risk of blood clot and stroke.
The cardiovascular.
Yeah.
And I also think, that just jumps into, I think we both are very frustrated by it, which is the lack of education for clinicians. Clinicians need to know what they're talking about. The amount of doctors we're seeing who are saying, I don't do that. When a patient comes, they've seen them maybe for their OB or their GYN care, and then they get into their, late 40s, early 50s, and have questions, or sometimes don't even ask about how are you feeling. There's just a kind of, I did your pap, I did your breast exam, I have a mammogram, bye, see you, in a couple of years. So I think that that's really important, that clinicians know what the options are, educate themselves about menopause. And that's particularly true for younger clinicians, I think, also. This is kind of the sense of like, oh yeah, that's that problem for the elders, the old ladies. But I think both Audrey and I feel it's very gratifying work to know that you can really help somebody. You can help someone have sex again. You can help somebody have orgasms again. You can bring joy, and to sleep. Because sleep deprivation is a real stressor, and we know that it's a stressor in cognitive decline. We can, I feel, it's not that one should treat. I know that's been a conversation in the feminist communities for a long time. I don't think it's mandatory, but I think you damn well better be able to opt it for a patient and know what you're offering, know what you're offering that patient. And give the patient the reassurance, as Audrey said, that the WHI and the misfires of that, we're still feeling today. And I think that's one of the motivations of doing this, is just trying to get more information out.
Yeah, I think the New York Times Magazine article, this website, just patients are intimidated when they see their provider, and if their provider doesn't ask the questions or dismisses them or prescribes Ambien or just says it'll get better,
live with it.
It's really doing them a disservice. And I do find in my practice that as my providers are aging with their patients, they're asking me more questions about menopause, and they're open to talking to patients more about it. And thankfully, we do have patients who I think feel, in general, comfortable asking questions. Although recently I had a patient who was just diagnosed with osteoporosis and had no idea that was associated with menopause and the drop in estrogen. And I can say I hadn't seen her for a few years, but I feel like our practice did her a disservice by not emphasizing that, and I was surprised.
Well, it's also the way girls and women are taught about their bodies, which is zilch. We're just in the dark. So why would you think that? I think the other thing that comes up a lot, which is another health issue for women in this age group, is the issue of increasing thyroid disorders, which can have a big impact on bone, and on sleep, and on weight gain, and on a lot of things. If you look at the symptomology of a low thyroid, it's often very much right in line with menopausal symptoms. And it's, the word hormonal, that's like crazy to a lot of people, and I think it's time that, we are the walking science, and it's time that science gave us the due, the respect, and the interest to put some money into really studying this stuff, because as even the article in the Times said, even a lot of the work around the cognitive stuff, we need to know. Mosconi's doing incredible work, but she needs to know more, we need to know more. People aren't looking, that's why I think dealing at the 40s and the perimenopause is a great intervention, because they're developing habits there that are becoming,
we're recording here? Okay.
Are becoming, embedded. you know, and the way they handle their stress. How do they handle the stress? Well, how much wine do you have? You know, I mean, I've certainly seen a lot of my patients, and I went through it too, actually. I mean, I can remember, you know, easily going to taking down a half a bottle of wine, you know, and sometimes it would even have more, and I wasn't even aware of it. But, you know, it was sort of like coming home and, you know, taking my jacket off and reaching for the bottle. But, you know, that for a lot of women is a very common occurrence. It's like that's what they need to have them calm down and sort of reset. So lots of times you're seeing elevated glucose levels, you're seeing elevated A1Cs. And that's a really, you know, lots of times we've had a conversation in the past about, are we doing the blood work? Is the GP doing the blood work? So a lot of times I think sometimes you can get some information by doing, you know, a fasting glucose or an A1C, and you can see if somebody's really high cholesterol. And I think women tend to expect, well, it could be the kinds of practices we have, but expect to have more conversation than they do often even with their GP. Mm-hmm. So I think then, I mean, also it's a time to intervene around thyroid issues. If you've got a family history of thyroid, you know, your aunt, your sister, your mother, your grandmother, you can be damn sure something's cooking there at some point. And you're looking, lots of times you'll see that a lot of women in that perimenopausal period are actually a little bit more, I mean, this is a controversial term in GYN, estrogen dominant, but meaning that they have a ratio and they're more sensitive to the estrogen. So you're seeing more breast swelling with their period. You're seeing
sometimes where the breast tenderness doesn't go away when the period
exactly
ends.
It sort of sticks around. It doesn't, work sort of, and then also particular kind of fat redistribution, even though we know that happens in the menopause, you start to see it earlier. The menopot, you know, the thing that when you wake up one day and all of a sudden, what's that? And it feels like it's dense and it feels like it just pops up. You know, I think these are real symptoms that a lot of women are having. But if you ask them if they're having their period and they say, oh, I'm skipping a little bit, but I usually get it. You're often missing that population and that time to educate.
Right. Well, that's what I think one of the wonderful things, as I mentioned, our patients are aging with us. So I have seen women from, you know, delivering their babies and now into menopause. And every year, and they have more of a relationship with me than they might with their primary care provider. Right. And especially, I think, post-COVID, so many doctors have either left practice or things are in flux, and it's hard to
lazy.
Well, but I think there's just also a huge demand on providers overall. So, but I always take the opportunity at a regular visit to have a little anticipatory conversation and to remind women that alcohol, that basically there's nothing redeeming about it, and that the original studies that said it's good for your heart were funded by the alcohol industry, and that it actually is a sleep disruptor such that you don't always know that your sleep is disrupted, these little micro awakenings. Right. And so I take the opportunity to encourage people to make sure they can stop drinking, to look at that, to look at some mindfulness or cognitive behavioral therapy if they're having issues around that, to try to substitute healthier behaviors. Instead of going home and taking your coat off and reaching for the glass of wine while you're cooking, maybe take that time to actually go for a walk before the sun sets, and to restructure.
Yeah, and I think also in line of that, certain ways in which you as a clinician can be educated about easy ways to help people manage stress. You know, like certain kinds of breath work. That doesn't mean sitting down and doing a Zen meditation for 20 minutes, right, which a lot of people find very difficult.
And also lifestyle things that help specifically with menopausal symptoms. I always joke I used to have to sit directly in front of the air conditioner to have my coffee in the morning, because as soon as I took a sip of the coffee,
It would make a flash. Yeah.
drenched. And then I remember one October where I stood in front of the air conditioner and refused to let my husband take it out of the window. Which again, I grapple with this environmental. It's terrible to keep the room cold, but it really helps with sleep and it helps with the symptoms and cutting out alcohol. And a lot of women voluntarily do that. They find that they don't tolerate it anymore. And also they're very motivated because it is, in general, a way to lose weight or at least cut out calories that are worthless.
Well, talking about calories, one of the things also that you see is, the obsession around weight, which is still just tragic in my book, is that women are still suffering under these body dysmorphias. And what you see often, and I think we've seen it certainly, is you start seeing much older women in bulimic and anorexic stages. One of the things I see a lot in younger women and in general, because of the way the culture has been shifted, they're really protein-centric in their diet, which does not serve their bones well at all, because a really heavy-duty protein-centric diet will leach out some of that calcium. And so I really try to get women to really try to look at some healthy fats, looking at your plant fats and your nut fats and things like that. And also remembering that carbohydrates can calm the body, that they are not the devil. So I like to tell a little bit also, because it's such an issue for women about the weight. The first thing, is this going to make me gain weight? And and a lot of times, you mentioned it when you were talking about it, but a lot of times estrogen actually, you will, your weight, that some of that belly fat that gets there will actually subside once on estrogen.
Well, and estrogen helps maintain muscle mass,
right.
Which is metabolically more active than fat. But again, that's where reminding them that exercise, weight-bearing exercise, strength training, all the things that are going to be good for their heart, good for their bones, is part of the healthy lifestyle that will ease them into the transition. And I think part of this whole conversation about menopause and the transition is that we're living 30, 40 potentially years, 50, who knows, longer afterwards. And so it's, yes, estrogen prevents osteoporosis, it's indicated for that, but if you didn't get the calcium-rich foods, the dairy or the plant-based foods or the fish with bones or the white beans, all these things have lots of calcium. If you didn't get those as you were getting older, but by age 30, really you're not starting at your best bone mass, and then
it's in decline.
Yeah, and then so I actually take the time when I'm counseling my 40 and 50-year-old women to remind them about what their children should be doing also, because it really is about addressing women's health across the lifespan and just
right.
Not just this transition. There are lots of other ones.
That is the end of part 2 in our series on understanding hormone replacement therapy, and there is still more. There is another part 3. Please join us as our clinicians continue to share their insights on menopause and women's health.